Well, good morning, good afternoon, and good evening to all of you. Thank you for joining us today for the final virtual session of, indeed, any session of PPP's Global Genomics Conference. And today we're going to focus on how to articulate the economic benefits of genomics. This concludes our Global Genomics Week, where we've hosted 3 virtual sessions and our in-person event at the Royal College of Surgeons in London yesterday. All of our sessions have been recorded and will be put up on our website soon. So if you missed anything, you can use that option to catch up on what you missed. Just to put our work into context, since February 2020, PPP has been carrying out its global genomics programs of work. Phase 1 considered how to bring the benefits of genome sequencing to the world, and Phase 2 is currently ongoing and considers what we mean by equity of access and return in global genomics. This work was inspired by both PPP's UK-focused work, the most recent element of which was our Genomic Revolution report, which we launched last October, but extends beyond that into rare disease, cell and gene therapy, clinical research, and other areas. And also by our work in partnership with the Diplomat magazine to convene discussions through the London diplomatic community, what we call the World Economic Series, and seeing challenges and hearing about opportunities from multiple perspectives. Our work, therefore, has a unique diplomatic angle to it. And as we know, diplomacy has played a central role in genomics since the Human Genome Project, first articulated in 1998 by a special committee of the US National Academy of Science, and later adopted through a series of 5-year plans jointly prepared by the National Institutes of Health and the Department of Energy of the United States. From the outset, the entire Human Genome Project was centered around 2 key principles. Firstly, by welcoming collaboration from any nation in an effort to move beyond borders and benefit from diverse approaches. And secondly, by requiring that all human genome sequence information be freely available and publicly available within 24 hours of its assembly. This was to ensure unrestricted access for scientists in academia and industry, thus enabling rapid and novel discoveries by researchers of all types. International collaboration and open access data have therefore been cornerstones of genomics since inception. And yet, notwithstanding the vision articulated by President Bill Clinton in 2003, that we must ensure that new genome science and its benefits will be directed towards making life better for all citizens of the world, never just a privileged few, access to the benefits of genome sequencing are not equally available to all. And in part, that is driven by the fact that the data sets which exist do not reflect the diversity of the global population. PPP's intention is not to duplicate work carried out by other organizations, but to socialize that work to a wider audience. We've intentionally created a platform for different voices and perspectives to be heard, uniquely bringing together academics, clinicians, ethicists, lawyers, international agency, industry partners, and members of the diplomatic community, from jurisdictions with well-developed genomics programs and ecosystem, and those at the very start of their journey, and importantly, from high and low and middle income countries. We did not lead with the science, but with policy. Which brings us to today and our Global Genomics Conference. We're grateful to our partners, Genomics England, LifeBit, Amazon Web Services, Illumina, Thermo Fisher Scientific, and the Wellcome Sanger Institute, who have enabled this conference to take place. As all of our discussions previously took place behind closed doors and under the Chatham House rule, we wanted to use this opportunity to open up our discussions on some of the key themes to a wider audience. And that is why it's so fantastic to have all of you here today. As with our other virtual sessions, and indeed the in-person events we held yesterday, we have picked topics from our previous work to explore in more detail. We've chosen to round off our virtual sessions with a specific exploration of how to articulate the economic benefits of genomics, which is the topic we explored in our last roundtable of the first phase of our Global Genomics program. If genomics and genome sequencing is the best opportunity to prepare for the next pandemic, and indeed for other transmissible diseases, as well as optimize the protection and preservation of population health and individual health, and yet genomic data continues to fail in reflecting the diversity of the global population, will it fail to bring those benefits equally to everybody? Do we not need to be able to articulate the economic benefits of focusing on such a program so that those who hold the purse strings, wherever they may exist in the genomics ecosystem, can better understand why it is economically advantageous to give this priority when there are so many competing economic demands? If the Human Genome Project and the sequencing of the human genome represented the greatest single achievement in the field of life sciences and showed great promise for all, for, in the words of President Clinton, making life better for all citizens of the world, not just a privileged few, How can we ensure that it's not solely those economies that can afford to invest significantly over multiple governments that get to reap the economic benefits by growing a thriving genomics ecosystem? And how do we determine economic benefits? Is that the creation of jobs and companies and tax revenue? Is that the only way of demonstrating economic benefit? What about the wider health economic benefits? The cost that can be saved by deploying genome sequencing to provide more targeted interventions more accurately and quickly? The reduced care burden, or the ability for people to return to work more quickly or not to become sick in the first place? How do we quantify these issues? It was surprising to me when we had these discussions that each jurisdiction seemed to adopt a different approach. And our Global Insights report noted that there are limited studies of the economic benefits to be derived from participating in genomics. And there seems to be no consistent approach globally about how this is to be assessed. We recommended that greater policy focus needs to be applied to how this should be considered, for example, through the lens of the wider societal benefits that can be derived, so that all jurisdictions are able to make a better assessment of the economic potential for them of focusing on genomics, if genomics is not to become the preserve of only jurisdictions or organizations that can afford to fund it. Now, a couple of reports are worth noting at this point, both of which have been published since our discussions, although they were alluded to. The 100,000 Genome Pilot on Rare Disease Diagnosis in Healthcare Preliminary Report in the New England Journal of Medicine and and the second report, Personalized Prescribing Using Pharmacogenomics to Improve Patient Outcomes. The Royal College of Physicians and the British Pharmacological Society published this recently. So to help us lead this particular discussion, I am delighted to welcome our panel of experts. Ilse Custers, who leads the Health, Economic and Outcome Research Working Group for the 1+Million Genomes Project. Professor Manap Pithpakaran from Genomics Thailand, Rob Annan, CEO of Genome Canada, and Professor Sir Mark Caulfield, former Chief Scientist at Genomics England, CEO of Barts Life Sciences, Professor at Queen Mary's University and President-elect of the British Pharmacological Society, who brings such extraordinary diversity of perspective and experience to these issues. And shortly, I will ask each of them to briefly introduce themselves. But before I turn to our speakers, just a couple of housekeeping points. Those of you who've joined one of these sessions before will know that we like to have a good discussion and very much welcome audience participation. The work of PPP does not lead with the science or the technology of genomics, but focuses on matters of policy and ethics. We've created this platform for everyone to share their perspectives. They are all relevant and they are all valuable. There are a couple of ways to get involved, either by raising your hand or by putting your comment into the chat function, and I will try to bring in as many of you as I can. Could I also encourage you to keep your line muted unless you have been invited to contribute to the discussion? One point to note is that Professor Sir Mark Caulfield is only able to join us for the first hour. So if you have any specific questions for him, make sure you get in quick. And so without further ado, let me turn to our speakers and ask them to briefly introduce themselves before we delve into the detail of this important topic. Ilse, can I call upon you first? We'd be delighted to hear what you have to say.
Yes, thank you very much. I'm really glad to be able to join this meeting today, and I hope to learn also from other perspectives. I'm involved in the 1+Million Genomes initiative since 2018. The goal is to achieve over 1 million genomes in 2022. I think we are a little bit late, but and to share with research. But more countries are coming up and developing national genome programs. Indeed, I'm coordinating the Health, Economic and Outcome Research Working Group. There are several working groups on different aspects, but health economic is a vital instrument in this initiative. And unfortunately, UK had to leave the initiative because of the Brexit, because we could have learned so much from them. But yeah, that's why I'm also joining today to learn more. Thank you very much.
Thank you, Ilse. Yeah, so we'll sweep over Brexit, but we'll help out with that interface. Manop, we would love to hear from you.
Hi, hi, Kate, and hi, everyone. Thanks for inviting me, and happy to be here. My name is Manop. I'm from Thailand. So I work at Sirat Hospital, Mahidol University. Somebody might heard this name before, but today I represent the national program they call Genomics Thailand. So Genomics Thailand is the national genome initiative in Thailand. So we represent at least one perspective from middle-income countries for national programs. Our aim is to utilize this genome technology and implement it in the healthcare system. At the same time, we want to use this opportunity to drive the economic impact also by integrating this program into we call Eastern Economic Corridor. It's one of the platform of Thailand to revitalize the newer set of the economic industries. As you know, that one of the strengths in Thailand in the industry is a healthcare service, and we would like to use this opportunity to integrate this genome technology service into a healthcare service industry that attract more patients and medical tourism from all over the world to Thailand. And this probably one of the our own goal to both bring this technology to the nationwide healthcare system at the same time to create economic impact of the countries.
Perfect. Thank you, Manop. Mark, would you like to go next?
Morning, everybody, or good afternoon or good evening. I'm Mark Caulfield. I was involved for 8 years in Genomics England in leading the 100,000 Genomes project and then converting that into a new national genomic medicine service, creating a new test directory, which is mandatory for use. And I've also been involved in the Royal College of Physicians British Pharmacological Society report on pharmacogenomics and the implementation of personalised medicine, which we're actively moving towards implementation. So it's a pleasure to be here. Thank you, Kate, for having me. And if you want to know more, there is a report that we published as part of this series, which is the Genomic Revolution. You can find it on the web, and that covers some of the areas that we're going to discuss today, but also there's a fabulous report on global work as well.
Thank you, Mark. Yes, I cited a couple of reports that have been published most recently, and I was kind of looking to see who had contributed. There were a lot of people on that 100,000 genomes report, but I hope we'll be able to unpick some of that in a little bit more detail. Last but by no means least, Rob Annan.
Hi, thanks, Kate. Good day, everyone. I'm joining you today from Canada's national capital, Ottawa. It's great to be here. I'm President and CEO of Genome Canada. Genome Canada is an independent organization, not-for-profit organization here in Canada that works very closely with our federal government to support genomics research across the country. We are a little different than many of the initiatives you might be familiar with in other countries insofar as we are working across various sectors. So we do a lot of work in health, of course, but we also work in everything from agriculture, fisheries, forestry, mining, energy, environment, and so on. And right from the very beginning, we were created really in the shadow of the Human Genome Project about 20 years ago. And our, right from the very beginning, our mandate has been very much about supporting economic impact through the application of genomics. And so I'm really looking forward to the conversation today. Looking forward to hearing from both my fellow panelists, but also all of you in attendance, and looking forward to the conversation. Thanks.
Perfect. Thank you, Rob. I mean, I think that this is quite interesting just from the outset of sort of slightly different approaches by different jurisdictions. And certainly in our global genomics program of work, we uncovered completely different approaches from different jurisdictions, which in and of itself was quite interesting. But hopefully, for the benefit of the audience, what we've tried to do today is identify some slightly different approaches, because I think they're all relevant, and within that might be the answer for you, because it just strikes us that if we can't articulate the economic benefits of something, then it's going to make it very difficult for policymakers to embrace this as a concept. So Ilse, shall we go to you first? I don't know whether you could briefly explain to the audience who may not or may be familiar with the 1+ million genome project. Do you want to just give us a little bit of a background? What what is it? What are you aiming for? And actually, what is the sort of main purpose or goal, if you like, of the Health Economic Working Group that you lead? What are you aiming to unpick there?
Yeah, thank you very much. Yes, the 1+ million genome was initiated by member states in 2018, and the goal is to have 1+ million genomes available for research in 2022. And obviously we are behind because I think we have now 26 member states have signed the agreement, but they are all starting except for the countries that already had a genome initiative. And there are 11 working groups. So there's a lot of data infrastructure, phenotypic data, ethical, legal, societal aspects is a working group. And one of the group is on health, economic and outcome research, which I coordinate. And what we try to achieve is maybe a little bit similar to the regulatory requirements, to have data that are able to be shared on health economics across Europe. So rather than, we know that for pharmaceuticals, each country has its own requirements and the healthcare systems are very different. But what we want to achieve is that we can accumulate evidence across Europe, because it's a totally new health economic environment, let's say. And health authorities are struggling how to evaluate. And we are talking about whole genome sequencing, but we are trying to explore more genetic testing. So that's what we aim to do with the working group. And it's we're struggling because sharing data is a difficult issue, but also methodology needs to be developed for how to explore this. So that's what our working group is working on.
Perfect, thank you. And I think it's interesting because the issues that you're articulating there, Ilse, about how this is challenging, this isn't an issue that's sort of, sometimes I think we kind of put it in a bit of a, oh, that's a low middle income country problem, but it's not, is it? Because what we're talking about here, the EU nations, not including the UK anymore, the EU nations, and how you're trying to sort of unpick this. So I would encourage everyone on the call, if you've got a question, don't feel there's no stupid questions in this topic, because I don't really think that anyone has kind of really nailed it. And that's why I think it's going to be interesting to hear the different perspectives of how different jurisdictions have approached it. Mark, I'm conscious that we're having such fun. 20 minutes have gone and you need to leave at 1 o'clock. But can I call upon you just in terms of, we've talked before about how, when we spent £300 million worth of UK taxpayers' money, what consideration was given to how you would know whether that had been a success at Genomics England? Would you be able to talk us through that a bit?
So yes, I mean, there were several key mission statements given to us, essentially to successfully complete the 100,000 genomes project to time and target, to use that as a trusted platform by public and patients, to engage public and patients throughout the process, to stimulate industry inward investment into genomics, both in the UK and elsewhere, and to make sure that we try to create a platform for the NHS adoption. And Kate, I would say that in the majority of those, it's a success in that we did deliver the project on time and target. We also, in parallel, planned, jointly with NHS England, a new genomic medicine service, and that involved creating a test directory. So we looked at 300,000 tests, upgraded 25% to new technologies, and created a directory. And the important thing is that the health system decided that if you didn't use that directory, you wouldn't be reimbursed. And that's quite an important thing. To make that dynamic and responsive, we built in something which we don't usually have in the UK NHS, which is an annual review of that test directory, so we could continually upgrade it with new knowledge. But that also has an economic value, Kate, because if you're reevaluating the tests, some may become cost ineffective, others may become cost effective. And this allows you to have the dynamism to respond to evolution of the market. The other thing we also did was we used the purchasing power of the project twice to significantly affect a major price point fall in the cost of a genome from Illumina. There are obviously other sequencing entities now that have entered the space. You know, people did tell us that it would cost us so much that we wouldn't be able to finish the project. And although it cost the government more to do than they'd originally anticipated, instead of 100 million, it was 300 million. Actually, what it's delivered is a new genomic medicine service. There are 7 regional hubs, 7 genomic medicine service alliances, which are the front end to the whole patient. And so wherever you are in England now, you should be able to get the same tests. So you have regional equity of access across 56 million people, and Scotland, Northern Ireland, and Wales will follow. And I suppose, Kate, the final point is, this is the sort of disruptive thing that governments can do, which health systems might take years to do on their own. And one of the reasons I like the EU project and the work in Canada is because what they're trying to do is to adapt to a multi-party, multi-nation situation, or multi-region in the case of Canada, where healthcare and academics may either be more closely joined or even less closely joined, or even where the federal government is no longer influential on what happens at regional or local level, because that's decided locally. And it's how we win the hearts and minds of the politicians that make the health system work that will characterize our collective success, because this is ready in certain areas for implementation in healthcare now. And the longer we take to do it, the more people who will continue on a diagnostic odyssey in rare disease or will not get the therapy they should in cancer. And of course, there's pharmacogenomics, which we've yet to touch on.
No, thank you, Mark. I mean, arguably, the UK is one of the leading jurisdictions when it comes to genomics. Do you think that we've only managed to achieve that because our government decided to fund it? Because if you've got other jurisdictions with other competing priorities that you know don't have that sort of same political will,
yeah,
you know. And I know that in the UK we do have public-private partnerships, and I think that the role that industry can play, I think, is really important. That's a subject that we try and unpick in other sessions, because otherwise it's just, if it's only the preserve of jurisdictions that can afford to fund it, it leaves us in a sort of quite curious position. But if you were starting all over again, would you do it the same way? Or do you think that there's a different approach that other jurisdictions might look to?
So I think that there are different approaches other jurisdictions could look at. If I look at the countries that are most advanced, there is significant public money from government invested. And I think some of the agencies, for example, Rob can speak to Genome Canada, but you know, if Genome Canada didn't exist, probably quite a lot of genomics in it that's coordinated would be less so in other words, the parts would become less than they are as a result of an overarching. And so my suggestion would be that people need to construct a system that works within their political system and allows them to progress this. And in Canada, that's very much working regionally, but also nationally. In the UK, because we've got a single payer and NHS, we have an advantage. But there were other reasons why the project succeeded. This area had been underinvested in, so the enthusiasm of 5,000 frontline NHS workers helped to drive the project forward. And then if we add in the fact that government were behind it, and then we add in that we had significant human capacity to deliver the project, although very few people had really deep knowledge about whole genomes, but they could get that. That's useful. So what I would say is there's a mixture of ingredients that are important. It's not simply government funding, and there are examples now of public-private partnerships, as you allude, around Biobank UK and Our Future Health, and these are proving very valuable platforms to achieve things that public funders probably wouldn't be able to achieve, particularly in the research arena. And I think that the government would now look to us, were we doing this again, to have some form of public-private partnership around, say, a revised 100,000 genomes mission in the future. I mean, there's certain areas that governments need to fund the entry to because they're unattractive to a public-private partnership, because there's no obvious potential output for the industry partner. So, for example, newborn sequencing is one area where there is a sensitivity to treatments on or deployment of treatments in early life, and there may be less interest from industry. Though I am seeing more interest now that we have a funded program from industry in being involved, because it gives you a new platform for early intervention before the disability or the harm has occurred. So what if we could change those lives and treat people who had treatable disorders in the first 5 years of life? And if you think about the quality of adjusted life years gained, it's between 17 and 44. And people here who work on late onset disorders will go, wow, how's that happen? Well, they're children, that's why. They've got a huge lifespan ahead of them. And the other thing is you're altering their life trajectory. So you can save in certain diseases between 144,000 a year and over 1 million. You know, for some of these children, it's hugely expensive to look after them with fixed disability. So what if we could change that? And I think this can be done in other jurisdictions on a mixed model.
Mm-hmm. No, that's super helpful. I mean, I think it's quite interesting at the in-person conference yesterday, Dame Sue Hill was talking about, you know, how the NHS, I mean, the very fact that we got genomics into the UK National Health Service and it being embraced, I think there's lots of interesting questions I'm sure that people will have about that. But Rob, Mark's mentioned the approach of Genome Canada and the Canadian approach. I mean, certainly when we've been having these discussions, your approach seems to be quite different to other jurisdictions where you've placed it as a key economic driver in and of itself alongside AI and quantum in the kind of Canadian budget. But can you just talk us through, you know, I think I'm right in saying that obviously genomics in healthcare is clearly important, but I think it's less than 50% of the application of genomics in Canada, which I think in and of itself is very interesting. But perhaps you could tell us a bit more.
Sure, Kate. And I'll come back. I'll come back to the health situation here in Canada, which is very complicated. You know, very sort of federated out, and as Mark sort of alluded to, you know, kind of complicated the subnational jurisdiction. But we have, in effect, made you know, kind of virtue out of necessity, and because of that, right from the very beginning, you know, health really in Canada is a contentious topic. It's constantly a challenge when there are efforts, particularly during COVID, but even before COVID, on kind of national coordination. Canada is a large country geographically, but reasonably small, you know, population-wise, just roughly 30 million people. And so really at the provincial level, some of the provinces is much, you know, very small actually. So working together is important, but it's hard. It's hard in health. And inevitably, you know, the results of efforts to kind of figure out how to solve this problem come back to kind of reopening the Constitution and so on, which is a huge third rail of Canadian kind of politics. So that's not really a possibility. So at Genome Canada, you know, when we were created, health was certainly part of our mandate, but actually, you know, we were created to have a much broader perspective than just that. We were created as an applied research organization, you know, like the other countries represented here on the call. You know, we have a robust research ecosystem in Canada with granting councils that take care of, you know, kind of investments in fundamental research, including in genomics. But when Genome Canada was created, we were really given the mandate to fund really big, large-scale initiatives, interdisciplinary initiatives, but always with a line of sight to implementation. So every one of our projects since the founding has had some kind of end user involved in whatever project we fund. In some cases, that is, you know, hospitals or provincial health authorities, but it's often industry or other, you know, kind of end users who will be able to apply the tools and technologies being developed in the field, as it were. And so we receive funding from the federal government, roughly, you know, on the balance of about $100 million a year. We then use that in effect in kind of a cost sharing model to bring others to the table. So yes, provincial governments, but often it's companies, it's foundations, it's others who are really interested in the end products of that work. So in the end, that federal investment represents about 40% of the funding. So it's really, you know, it's a partnership model, often public-private, sometimes public-public, but regardless, there has to be somebody in the mix here who says, yeah, we actually see a way to bring this into the clinic, into the market, or what have you. We do track, you know, we track all of the impacts. I'm sure we'll talk more about kind of tracking economic impact as we go forward. And it ranges from, kind of like just basic output measures, which are things like, students trained, jobs created, we've, patents and licenses and so on. There have been more than 100 companies have spun out of the projects we've supported over the years. And these really do run the range, as I said off the top, a lot of work in agriculture, a lot of work in forestry, which is a huge sector for Canada, of course, fisheries as well, but also energy, as we think about, kind of a more sustainable energy, sustainable biomanufacturing, and so on. We also have a really, one of our most popular programs is something called the Genomics Application Partnership Program. This is literally a private public partnership program that matches academics with companies to actually bring genomics to companies into sectors that don't usually use that kind of technology. So it's really used as an economic lever. I mean, it's baked into the structure that we have with our federal government. We are actually funded not through Health Canada, but through the Department of Economic Development. So Innovation, Science, and Economic Development funds us. And as you alluded to, even just last year, the federal government announced a new sort of investment of $400 million in a pan-Canadian genomic strategy, which is really focused on this economic impact and sets up genomics alongside other sort of platform technologies like AI and quantum as economic drivers for the future. And that really is meant to be felt right across the economy. So it really is a different model in a way. Like you said, it's just about 50% of our funding goes to health-related genomics and 50% in these other areas. But I will say a couple of things just about the health side, because it is complicated. So Canada, just very briefly, and there won't be a test on this or anything, but our health system is very complicated. It's federated. There are 13 different provincial and regional health systems across Canada, and then the federal government has responsibility for a few other sort of health systems for Indigenous peoples in Canada, as well as military, prison, and so on. So it's a very broad and complex system. The federal government does have responsibility for sort of national standards, as well as, in a sense, kind of managing broad-based funding across the ecosystem. So they do have real influence, but it's largely a provincial matter. And that gets to kind of Mark's point, where when we want to do things at the national level, it really is, in a sense, kind of winning the hearts and minds. And we have to work from a bottom-up perspective. Canada very much is a country of regions, and so there are no sort of kind of top-down, one-size-fits-all models. So we have, for instance, a project in rare disease called All for One, which is built from a variety of projects that we've supported for a number of years, but is now actually working with the clinicians, the researchers, and the provincial health authorities in 6 different provinces to actually build a small-scale kind of ecosystem that allows for sharing of data, sharing of best practice, and in a coordination of effort across those jurisdictions among a pretty small and very motivated group that then serves as, in a sense, kind of a bit of a test bed for us to then grow out kind of more national initiatives. So in this case here, it's really not just about kind of making the big economic case from the clinic. It's actually kind of winning it region by region and almost kind of government by government across the board. So, we're working hard to solve issues around, the data sharing and so on and so forth. But in many ways, it's actually this kind of hearts and minds thing that Mark talked about in terms of getting people to sign on to an initiative when the incentives aren't always totally clear for them.
Thank you, Rob. And I think it's interesting in terms of some of the discussions we've had about the approach that Genome Canada as a funder is taking, sort of looking much more broadly at, like a mission sort of enabling rather than individual project, and having that much bigger picture so that you're considering the kind of a range of issues from the outset, not just like, oh, that looks interesting, let's just fund that and see what happens. And I think that also has to be important. We'll probably come back to that. Manop. So we've talked before, you mentioned in the introduction that Thailand has included genomics alongside a number of other matters as part of your Eastern Economic Corridor strategy. And I think I'm right in saying this whole concept of hearts and minds in policymakers, that you had quite a number of physicians, people with medical backgrounds as part of the cabinet at the time that genomics was identified as a driver. But maybe you can tell us, I think that's really interesting. This is to Mark's point about, in the UK, did we have political support because David Cameron had a son who suffered from a rare disease? I think that there's an interesting point there, but Manok, perhaps you can tell us about some of your experiences from the Thailand perspective.
Yeah, sure, Kate. I think it's probably Thailand, the way that this national initiative was brought up, I think is quite different from the others, especially for Thailand. I can say this in the view of middle income country, the approach of bringing this genomic to be a national program needs to be different. Obviously, people still perceive as genomic as the high tech, high cost, highly sophisticated, and in terms of the middle income country mentality, a lot of people say it is pricey. No one cannot anyone can afford it. Why we have to invest in it? So it's going to be difficult to sell, especially if you try to sell on the platform of diagnosing rare diseases, something like that. So so we need to come up with a different approach. Unfortunately, at that time, the cabinet, 3 of the cabinet members in Thailand happened to come from the academic institute. 2 who are minister of public health. The other one is minister of higher education. They both were the past president of university. So, and the other one from Science Technology Ministry, he was a pharmacist. So it's easier to sell this idea. At the same time of the EEC, the Eastern Economic Corridor come up. I think people understand that the Thailand need new economic engines. And one of the strengths in Thailand from the past until now is the healthcare service industry. And there's been voices from the sector for quite some time that we need some economic drive, especially in the healthcare industry. So Genomics Thailand has a draft based on one of the economic impact interests to begin with. And one of the unique system, the healthcare system in Thailand is on one side, we have a single payer national health service similar. So we have universal health coverage that, get the people who are in Thailand will go to the healthcare and get reimbursed from government. At the same time, in parallel, we do have a private hospital network, which is quite huge. They accept both domestic patients and also international patients to come in, and they have self-pay. They have a private health insurance to support, and both sides probably have probably almost similar budget in terms of the healthcare. So on one side, we need to set up the program to address the benefit that how we can integrate this genome technology in the healthcare system, especially for universal health coverage. And the other side, how do we strengthen or bring the health service industry, especially for the private hospital, to the next level? And that's one of our mission of Genomics Thailand. So that's why our approach, instead of starting with rare disease, which is obviously it's very difficult to sell, the policymaker. So we have to come up with something that's easier to understand. For example, pharmacogenomics, how do we implement this to avoid people getting adverse reaction from the medications, or cancer, how do we demonstrate the benefit of, like, for example, germline testing for BRCA for breast cancer, which is right now become a nationwide reimbursement starting this year for all eligible Thai patients would get this test for free, for example. That's one of the achievement that we could do.
Perfect. Thank you, Manop. And you've mentioned pharmacogenomics there, and Mark mentioned pharmacogenomics. So maybe we just ought to sort of pick up on that. Mark, in terms of that most recent report that you mentioned,
Yeah.
would it be worth briefly, only because I know that you've got to leave shortly, just talking through, you know, the kind of economic benefits that can be gained from this approach to pharmacogenomics?
It's okay. I think this is probably observed in other health systems, but one of the drivers to this is that about 6.5% of hospital admissions in the United Kingdom are due to adverse reactions to medicines of one sort or another. They're not all due to your or my genome interacting with medicines, but a proportion of those will be. This costs somewhere between 1 billion and 2 billion to the NHS a year. And the deployment of pharmacogenomics in two ways could influence this, and particularly in response mode testing. So that's where someone has an adverse response and they then come and they have a test of some sort, usually a genomic test that explains their problem. And the findings that we've made at Genomics England, which is looking at 76,000 whole genomes, is that 99.5% of us here, and it doesn't matter what ancestry you are, so far as we've studied, will have at least one gene-drug pair that will interact with a commonly prescribed drug that's prescribed in most health systems worldwide. So there are about 43 gene-drug pairs where you might want to have a genomic test available to respond to an individual so that you can understand that adverse reaction, stop the medicine, and avoid harm and potentially reduce length of stay. Probably in the longer term, as genomics becomes more broadly available, you could conceive of having preemptive testing where you might carry either in an app on your phone or in your medical record a list of medicines that you should avoid. Now, there is an opportunity to an earlier point I made about doing things with public and patients, that an app can provide an interaction point, but it can also provide the patient with the ability to check out whether a medicine they're about to be prescribed would be harmful for them. Now, that doesn't mean to say the person won't get a side effect, but it means to say that if you've excluded the commonly known gene-drug interactions, then you've improved potential for safety. And the reality is, Kate, 25% of us for of these things. So Diffrig Hughes from the Bangor University has done some health economics on this. And it turns out that running simple chip-based analyses or even targeted panels is actually quite cost effective if you compare it to the potential for harm. Now, we live globally in a world of an aging population with multimorbidity, and therefore polypharmacy, many medicines prescribed to the same individual, is quite common. So I do think that the approach taken by Genome Thailand to focus on PGX is important. And based on the data I've shared with you, it is population-wide relevance. So it's relevant potentially to everyone, or everyone who will be exposed to those medicines. So that's why we published the report we did from the Royal College of Physicians and the British Pharmacological Society to say the moment's now for personalised prescribing to be implemented, and particularly for pharmacogenomics to be picked up. And the NHS are working on how they might do that today. That has workforce consequences. So you need a network of decision support to support frontline workers. Typically, in our case, that would be family physicians or primary care. But that can be done by using the hugely talented pharmacy base that we have in Britain. And that would probably also potentially be true in other countries around the world. So you could remove some of the hard effort and hard graft here by involving a profession who are perfectly placed to support the public and patients in doing this, which they do every day, and advising them on medicines.
Mm-hmm. No, I mean, it's an excellent point. In fact, Manop, I want to come to you because I think that this whole point around the utilization of pharmacogenomics in Thailand is really quite impressive. That just sounds patronizing. I don't want you to think that I'm being patronizing. I think that what you've done in terms of, approach to Stevens-Johnson syndrome, I think is very powerful, but maybe you could tell us a little bit more about that.
Yeah, I think it's probably quite unique in our population that Thai, probably similar to several Asian countries, population that we do harbor significant alleles that make us predisposed to Stevens-Johnson or TENS for certain drugs like carbamazepine or allopurinol, which is widely prescribed in clinical practice. At the peak, around 10 years ago, roughly about 1,500 new cases of Stevens-Johnson syndrome occur every year in Thailand. And majority of those are related to those two common drugs, which is carbamazepine and allopurinol. So since then, we do adopt the nationwide program from pharmacogenomic testing for any patients who clinically indicated to use those either one of the drugs. We do offer the testing for free for universal health coverage, and those tests cost around $30 US, and just one-time testing. And right now, the incidence of new cases of Stevens-Johnson syndrome dropped from the peak, 10 years ago, to right now is probably less than 30% of the peak. So we save around 1,000 new cases a year by implementing this simple test alone. Now, obviously, we can't eliminate all of them yet. Some of the patients would probably get this medication from over the counter or something like that, something that we cannot, close all the loophole. But in the hospital setting, all of the patients who are needed to use this medication will get access for the testing for free.
Perfect. Thank you, Manop. And I think that's very kind of the power, the significant impact. I mean, Stevens-Johnson syndrome, we've talked about this before, that's pretty horrendous. But the fact that you've almost been able to eradicate it, that must be such a saving to the Thai health system and your budget. So that must be, other examples such as that, must be out there. I think there's a really interesting point also, this whole concept of, what are we measuring here? So Rob, you've talked about, training, job creation. I know that, for example, the ABI and the Sanger Institute in the UK commissioned a report that looked at how many jobs we created as a result of our genomics ecosystem being advanced in the UK. How many, are we counting patents? Are we counting what are we even counting? The study that was done that examined, the $3.3 billion US that were invested in the Human Genome Project, that neatly they counted up all the jobs, primary and secondary, the amount of tax revenue they created. But is there, how do we calculate or measure some of these broader societal impacts, that people either don't get ill in the first place, or they are, Mark's talked about this sort of diagnosis odyssey. You can find out what's, the cause of a problem much more quickly. You don't get ill in the first place. You can return to work. You don't have to take time off work to look after a sick relative. How do we approach any of those sorts of things? Is that what any of those on this call more broadly, or the speakers, is that something that you try and assess? And I think that it's partly covered in the 100,000 genome report, but I don't know, does anyone have any thoughts on how you would approach that? Mark's got some good examples, I know that.
Sorry, Kate, in terms of evaluating economically the impact, yeah. So we did do some work on this, and there's more ongoing work which is not yet published. But we looked at 2,183 families who we enrolled in the pilot of the program, and that's in the New England Journal link on your thing, which you can download. It's freely available, open access. And in there, we looked at children born after 2003 And to our surprise, I mean, maybe we shouldn't have been surprised by this, but they attended 68 hospital appointments on average over a 6-year period, and they didn't get a diagnosis. When we did get them a diagnosis from a whole genome, and 25% of them secured a diagnosis, they migrated to a pattern of hospital attendance that was fewer, much more focused episodes of care. We estimated that for each child in the project, they took 6 years and spent £15,310 sterling in not getting an answer. And we spent a few $100s on a whole genome and got them an answer. So we have to think about the economics of this differentially from how we conventionally do so. So if we're going to measure it in very difficult outcomes that we do for common diseases and try and port that across to rare disease, it doesn't work. But we're quite happy because these costs are buried inside the system and we don't see them visibly, and they occur over years, to not pull that out. And now I think we can. And with the advent of greater use of health data around the world, I think electronic health data will be liberating in terms of new ways of approaching the economic value of things. Because, you know, if you or I said to somebody who was in charge of paying for this in the NHS, would you like to spend £15,310 on not getting the answer, or would you rather spend a few £100 on getting the answer? I think we know what their actual answer would be. I mean, the total cost of that program was between 87 million and 108 million. And some of the people, the adults, hadn't got a diagnosis for 30 years. So they've been wandering around the health system. And the problem with this, Kate, is in rare disease, people are heavy users of the system. And then you have to think about the total societal cost of this, because around the outside of this, usually one parent in a family of a very disabled child will not be working. They won't be contributing to the economy. There will be carers. There will be additional social input to that family. And there may even be specialist hospitals involved in various other things. So the cost of this is quite substantial. So we do need to factor that in properly. In cancer, I think the cost effectiveness, if I'm honest, Kate, is around how you rationally apply the latest therapies, some of which are pretty expensive, but you know that you're applying them to best effect. So you can delineate the people who respond. So instead of simply giving everyone with a particular type of cancer an expensive therapy, you can target it. Now, that won't work for everyone, but we did find in the 100,000 Genomes project that approximately 25% of the results we returned to the West Midlands Genomic Medicine Centre were used in clinical practice to alter care for patients. In some cases, to Genome Thailand strategy, it was about avoiding harm because we knew that they possessed a deleterious genetic makeup and they had some defective DPYD, which meant that they were exposed to very high levels of certain chemotherapies, and therefore they would have had harm. And they could either have reduced dose or avoid the medicine altogether as a result of that knowledge. And now we have preemptive DPYD testing. So if you're going to go on to either 5-fluorouracil or capecitabine, the NHS will test you. So partly as a result of that work, but partly as a result of work done around the world. And that's very cost effective because really ill people in chemotherapy are usually admitted to hospital. So those are some cost effectiveness observations from the 100K.
Perfect. That's really helpful. Ilse, I'm conscious that we've not come back to you, but let me just ask you. So you're trying to coordinate all the EU member states. Are they asking the same questions of kind of how do they have a common approach? Are they asking you completely different questions as to how to approach health economic evaluation? What's some of the challenges that you face with just trying to corral that cohort?
Yes, thank you very much. And I'm happy to learn from all the observations. And what we learned from most of the European countries is that they don't know how to evaluate clinical efficacy. Of course, contrary to European regulations and the regulatory, scientific benefits, there is no common approach for economic evaluation across Europe. So every country has specific things. And what the goal of our working group is to try to make recommendations, because we are not health authorities, how to approach diagnostics, including whole genome sequencing. But we are facing so much difficulties because there are so many other costs and values to incorporate rather than for pharmaceuticals. So there's a wider benefit for if you have a genome sequence, it has a future value. And so these are the discussions that we have at the moment. Also we have a few use cases. So we have rare diseases, cancer, infectious diseases, and common complex diseases. So for all of these use cases, there are different costs and benefits to elaborate on. And we try to get some sort of a framework that every country can fill in for their own health insurance system, let's say, but especially to generate wider economic evidence. But I was very interested in I think Mark almost left. Yeah, UK, unfortunately, they left, but we are very happy to learn from the UK experiences. What methodology did they use? What were their evaluations? Because we learned that they are also framing. We all know in start of a genomics program that you have to invest heavily up front. Are you taking all these costs in considerations for the data infrastructure, data storage, etc.? Because you will never be cost efficient for a single patient. On the other side, there is this hereditary cost benefit for specific patients that all the systems are based on, but we have a wider benefit for future research, etc. So that's what we are struggling with, and then to cooperate with a lot of countries. Our main question is actually the patient pathway, the whole genome sequencing pathway. What costs to take into consideration and what benefits to take into consideration. That's actually our main question at the moment. And furthermore, how to share the results across Europe. The working group really thinks we have to share data, and it's maybe a policy. Data are not shared so easily.
Yeah, I mean, data share, we talked quite a bit about this, what we have, and we also touched on it yesterday, but whether this concept of data sharing is causing the confusion, because actually you can create trusted research environments so the data never leaves. And actually that does solve quite a lot of the conundrum, but it's not the whole answer, isn't. Mark's going to leave in 1 minute. I don't know whether you wanted to sort of share some final thoughts, Mark. Because I think that what Ilse's saying, it's very difficult.
Ilse raises some important points, Kate. When we talk about the figures and the cost of it, we do include some element of cost of storage of the genomes and processing. In every part of this, the more you can automate the process, and you can't fully automate it today, is you can create cost efficiencies. But then I think where one has to come at this from is, what is the cost of some of these diseases if you don't do this? And what are you already spending on these diseases? And it's quite substantial sums. So if I say a child over 6-7 years of life will cost about £15,000, then, you know, even if the cost of a genome is below £400 or £500, and then you have £100 of storage and processing on top, that actually does look readily cost effective if you think about that in that way. And so I think, Ilse, when I think about this, what I think is you and I must challenge some of the traditional cost models, which tend to put you down a linear route to cost effectiveness, when in fact there may be disease specific elements of this. And you know, I may have left genomics in, but I'll always be happy to help my European colleagues. I spend a lot of time supporting some of the Delphi work you've done in the 1 million genomes project, and I'm very keen to see global adoption. That's the reason I'm here, Kate. Thank you for having me, by the way.
Well, you're most welcome. Thank you very much for coming, Mark. That's what I say. I don't know how long you're going to be able to stay on, because I think we were lucky to even get an hour of your time, but we do thank you very much for sharing your insights, and I'm sure that Ilse will be. Oh, Kai says, don't go. Kai, quickly ask the question and see if you can tempt Mark to stay. And then Paul, I see you've got your hand up as well. We'll come to you in a second. But Kai.
I just wanted to make a comment on what Mark and others have said. Sickle cell disorder, which I'm sure Mark is familiar with, is the most common genetic blood disorder in the world, according to the World Health Organization. And I could give you data and figures on it. But you see, there is a chap called Jonathan Salado, and he's done papers called The Cost Effectiveness of Hypothetical Cell and Gene Therapy Cure for Sickle Cell Disease. And what you find within this, and he's used quality of life things, so-called QALYs, quality adjusted life year. And I've used those when we've been involved as members of bodies that are approving treatments. And it's all very interesting. And I've often said, well, surely this should be an international standard for QALYs so that we can see that the benefits in terms of life to individuals. Now, when you look at a condition like sickle cell, you'll know that in sub-Saharan Africa, 4 in 5 children die. In fact, it was quite high in America before prophylactic forms of infection control, penicillin effectively came in. So you have a condition here that causes incremental damage through the repeated VOCs, vaso-occlusive crisis, meaning that these challenges that are osteoporosis, and you've got hip and other surgery that's required constantly through life. You have the risk of strokes. This is a medical emergency. The vaso-occlusive crisis are regular pain episodes that require people to be hospitalized on a regular basis. And that's very expensive in terms of the economics of it. You've also got the need for patients to have transcranial Doppler, MRIs, X-rays, all these medical appointments that you've just talked about, ophthalmic issues, psychotherapy issues, phlebotomy issues, pathology issues, psychological issues, chelation issues because of iron overload. I won't keep going on because I think I've made the point. The savings that you could get for having a cure for children, as you made the point, from a young age, for adults, because cures are available, makes the healthcare economics a no-brainer. Yet we constantly push in terms of, why are we not getting these treatments through? Now, we did a session yesterday. I won't go into that, might explain some of it, but I'm just wanting to inform you in terms of when you look at these patients, their families are torn apart by the fact of the stigma that is associated with having this condition. The having to have people not go to work when you get to an age where you can work, having to explain why you can't be there for 2 weeks at a time, having to do this when the population generally, as is identified, 66% of people with sickle cell disorder live in our most deprived communities. If we had treatments, it would mean that such people would be far more productive within society. For people with sickle cell, quite literally, that have had CRISPR, and there's been 45 in America cured, it's like having a new life, free from the worry of all the other comorbidities that come along with this condition, for which you still have to go time and time again into hospital, time and time again need for physiotherapy and rehab. The costs, I just wanted you to hear before you go, are phenomenal for sickle cell disorder. And I put the question in terms of the commercial position of many of our pharma organizations should cause them to drive to have a better social conscience in some areas of their work, so that for things like I've just described to you, it really should be something that they feel the need to get involved in and make more people better, so there is less stress on the medical systems around the world. And that is really why many people here come into being medical professionals, because they want to make people better. Thank you.
Kate, would you like me to
There you go,
respond?
Mark.
So, Guy, I can only agree with you completely, really. So first off, at the moment, gene therapies are expensive, but we need to chart a route to making them more affordable. One way is to reduce the cost of doing the research into their effectiveness. And one of the things we did at Genomics England with the NHS is decide that we would offer research to everyone who participated. So if a therapy emerged, say for sickle cell, if they were in that cohort, and they'd given consent for research, we could find them, recall them, and give them that opportunity. But then we could use the fact that we did that research, and because we had a platform and could find the people and could contribute, the trial could be done more cost effectively. And then as a result, that cost effectiveness could be passed on to the use of that drug in the clinic and how much it costs for the NHS to buy it. So there has to be a way of navigating this. We have seen NHS England through the Accelerated Access Collaborative begin to adopt therapy. So the spinal muscular atrophy therapy, which is for floppy babies where their muscles and nervous system doesn't work from early in life, that therapy is now being used in the NHS. And I think we're seeing the beginning of people understanding the complexity of the terrible life people have with disorders like cystic fibrosis, and that because it's becoming within our grasp to change this, we need to evolve our thinking about how we're going to do this, because we are otherwise going to continue to spend a lot of money on repetitive observation of their decline with that condition in multiple hospitalizations, which are in themselves expensive, as I've shared with you earlier. So I completely agree. And I also agree about companies and how low middle income countries should be looked at. We've seen some of that, but I think we need to go further. That's about countries that can do this, standing up and being counted and doing the trials that make these medicines more cost effective, so that that benefit can be shared globally and not confined to the United Kingdom or any wealthy country.
No, 100%. I mean, look, we can do a whole day on this.
We
But Mark's now supposed to be going somewhere else.
Yes.
But this point that you raised, Kai, and that Mark's just alluded to there, you know, we're trying to unpick some of those issues about, you know, what do we mean by equity of access and return in genomics? And we have to come at it through the lens of genomics. If we make it too broad, it becomes just too much. But this whole concept, I've had some interesting discussions about how there just needs to be kind of investor-led change in pharmaceuticals to, you know, there to be, I think you described it as having better social conscience. And I think that that's a really important point, but we'll come back to that. Well, we can carry on that theme through this discussion, but I think you raised some really important points. And this concept of this economic, you know, it's not just, oh, that would be a nice thing to do. You know, there's an economic imperative to it as well, which, yeah, it's just bewilders me, some of the points that get made around that space. But I think that you've articulated that perfectly, and I'm sure that we'll continue that discussion. Mark, if you need to go, then fabulous. Thank you very much. Thank you so much for your contribution, and we'll see you next time. Paul Jones, you've got your hand up. What would you like to say?
I have, Kate. Could I just respond to one of the questions you asked and pick up on this theme of measuring the societal or broader impact from multiple perspectives? Because I've been grappling with this question ever since I had the privilege in the early days of working alongside Mark at Genomics England back in 2013, 14, 15, early days. But also when I was at Illumina for a number of years, I was leading the agenda around large-scale programs, the interface into what we call population genomics initiatives. And we were constantly challenged with this question of, how do you make the case? How do you justify the rationale? And one of the things that we did over a 2-year period was build an approach that took what we call a macro perspective, or a macro benefits framework, as we define it. And I should say I'm no longer with Illumina. I left a year ago, but it was an interesting lesson through going through that process of, if you like, identifying the different stakeholders who were involved in these large-scale programs, right from government, clinical researchers, through to patients and industry interfaces. Each of the stakeholders were involved and engaged, but they often defined value in very different ways. And how do you characterize that, capture it, make it quantitative where you can, but even qualitative assessment is useful. And if you can package that up and work with individual countries to inform the model as to what they see as being valuable, it's incredibly powerful. We worked with ILSA, particularly at the interface into the 1+million, but one of the challenges that we certainly experienced is because I was sat within Illumina when we developed it, there was an inherent, if I can put it this way, mistrust of the output, in that it was an economic model that reinforced the value of doing whole genome sequencing at the interface into large-scale programs. And there was this element of, but it's industry sponsored, so therefore there's no doubt you're going to promote its benefits. And so it was almost like a call out to say there is some work in this space. There has been significant investment of time to create these models. My personal belief is that they should be open sourced so that actually the community can engage around them, and that we can start as a community to share the insights about how we do drive measurement of this endeavor on a much more robust basis than just purely the health economic angle, which is very, very laudable and needed, but there is a broader perspective than that I think is very, very critical.
Thank you, Paul. I mean, we've spoken before about this model of which you speak, and it struck me as there just was nothing else that we found that came anywhere close to what you're talking about. And I think that the challenges that ILSA is articulating, this is kind of a common theme across many jurisdictions, and the way that we approach it in the UK is not the same, necessarily the right way. I mean, Manop's got all sorts of challenges in terms of, his cost base is higher because he's not sequencing in the same volume as a developed genomics ecosystem. So his costs are more. So proportionately, it's more expensive. So, some quite interesting points around that. We might come back to you, Paul, because I think that ILSA is going to want to ask you some questions. But anyway, this is just going to be some therapy session for ILSA, I think, before her next working group. But Rob, from your perspective, we talk about this evaluation point, evaluation. And I know that that's something that Genome Canada is kind of really stepped up on. But do you want to just talk us through some of those and maybe how you've approached some of these issues yourself? Well, not you personally.
Yeah, sure, Kate. This is great, and I really appreciate the interventions from both Paul and Kai. I think, and they pick up on exactly, this point. I think the conversation we're having here is really important, and thinking about the economic impact, and I'll think more about the health side, but it's true across all of our sectors. Kind of coming up with really persuasive quantitative evidence for cost effectiveness, for instance, or return on investment is very valuable. It gets to a point though where I think, one has to ask the question, well, evaluation for what reason? So if one is evaluating to try to understand where your cost centers are and how you could address those and make them, less expensive so they're more broadly available, that's one set of questions you might ask. If instead the point of evaluation is in effect to convince policymakers, decision makers, and so on to make the investments necessary or to adopt certain technologies into the sort of standards of care, it's a different set of questions that you're looking to ask. And I actually think that despite the fact that I'm sure many of us on this call are scientists and perhaps biased towards the quantitative end of the spectrum, I have certainly come to appreciate the real value of doing good qualitative work. The quantitative work actually oftentimes it can be misleading. I mean, to Kai's point, when he talked about the broad spectrum of impacts that sickle cell has in terms of the economic impact, it is so broad and so diffuse that the ability to capture all of it is practically impossible. You're going to miss things, and if you're missing things, and then there's going to be some inherent inaccuracies in your overall calculations. And so instead, you bolster. It's important to do as much of that quantitative work as you can, and we do that. But you do want to then be able to bring to the table the qualitative side, which is this is the lived experience of people who are managing sickle cell, for instance, or other genetic diseases. Here are the the impacts that these kinds of interventions can have on families, on the psychological impact, on communities, and so on. And those two threads of argument, in a sense, are persuasive in different ways and persuade different different people. I know for me, when I go to our Department of Finance and you speak to like a senior official who really they want to see the numbers, right? That's fine. If you're speaking to a minister, right? If you're speaking to a minister and you want to talk about the impact it has on communities or families, it doesn't mean that it's, this is my previous scientific bias. This isn't like feel good, soft, wishy-washy stories. This is real qualitative work. Like, we've talked to communities, we've talked to people, we know what this can do. And this is the impact. And that's how you really do motivate a lot of change. So I think for us, in the case of, there's lots of examples, right? Companies that we help support in the early stages, to what degree can we draw a direct line between their eventual success and our intervention and calculate that as part of our economic impact statement? Sure, we can in effect make that argument, but when you can package that with the story of how our investment allowed them to adopt a particular technology that then took them over the hump, that animates the sort of the imagination of the decision makers to say, I get what you're trying to do, I get how genomics can help, and that can actually motivate action. So I really do find in our experience the quantitative side is important, but without that qualitative work and without the narrative that captures the real kind of essence of what you're doing, you're much less persuasive, frankly.
No, 100%. And all of this, is it not? All of this work that we're seeking to coordinate is all about collation of evidence, collation of examples, trying to bring different perspectives, because the challenges are not the same everywhere. And even in the UK, where we've got a very advanced genomics ecosystem, we spent a lot of yesterday, Kai was one of our panelists, and Sagira's on here as well, talking about what are the barriers to creating greater diversity within genomics, not just in the data set, but the data set is important. But in the whole ecosystem more broadly, how do we get more, better representation? How if we don't solve some of these issues, then we're just going to create, this is my point about entirety of our global genomics work. If we cannot address some of these issues, we are driving health inequalities. Genomics is driving health inequality because it's not equally available to everybody. It's not, the data is not there. And so part of the challenge must be, how do we combine some of these issues to ensure that the benefits, this is the whole fundamental premise of our work. How can we bring the benefit? How can we articulate how to bring the benefit of genome sequencing more equitably to everyone everywhere? And in part, that's about how do you demonstrate that there's a benefit. It's going to have an economic benefit to do it, because to Manop's point, in Thailand, it's just like, well, I'm not sure about that, but you've got to start, because if you do not collate your data, you're never going to get anywhere. And I think that speaks a little bit to Kai's point about, we could do all this amazing stuff, but we're not doing it. And why aren't we doing it? Think Kai, you put something in the chat, and this I think speaks to this social conscience point about Pfizer supplying 23 treatments to low-income countries at cost price. That's extraordinary, because I just find it just bewilders me that there's still this concept that the only answer to some of this is, you just have to wait for it to come off patent. Really? So I'm very pleased to hear that. We need to sort of investigate that in a little bit more detail. Manop, did you have any thoughts on what we've been talking about?
Yeah, thank you. I think it's Kai has raised very interesting questions about the quality also. I think it's obviously, in terms of scientific communities and also doctors who is taking care of those horrible diseases, we know that this technology helps a lot in terms of the quality of life of the patients. But to measure those and explain in numbers to policymaker is a different stories. I think, for example, the quality, Kate has mentioned about the price and the cost of sequencing, are quite different from country to countries. Lower middle income countries, the cost of doing one sequence are much higher compared to the Western countries. On the other hand, when you measure quality, the threshold in UK, I don't know how much, it's probably like, 20, 30,000 pounds, right? In Thailand, could be like only $3,000 to $4,000. Yeah, how do you measure this and sell those to policymakers? It's quite hard compared to one country to country. So that's why each country have different approach on bringing this technology to the table, I think.
No, 100%. And I think that is important. I think that what we're trying to explore here are what lessons can we learn from each other in terms of, you know, Ilse's there wrestling with the EU nations who are asking her like a million different questions. We've got one approach from the Canadian perspective. We've got a different approach from the Thai perspective. The UK adopted a totally different perspective. I think that we started, this is sort of slight simplification, we started off and then evaluated it afterwards, rather than, you know, having to sort of go through the proof process before we started. That's a gross simplification. Good. Ilse, and let me just, what would be useful to you? Because what's going to be useful to you is going to be useful to lots of other people as well. What would it be useful for you to see? I mean, and Paul might, you know, have some insights on this, because I think that every jurisdiction's different inherently, but there must be some key guiding principles that, you know, of where you might even begin looking at some of these things. What do you think that your member states would welcome in terms of trying to work out how to answer some of these questions?
Well, I think in principle that there is a new way to evaluate diagnostics rather than the national health authorities in each of the member states. They evaluate diagnostics sometimes as pharmaceuticals. And we all know the mama print, or I don't know how you call it in your country, but that's ridiculous to have an RCT. So we need to define patient pathways. What are the best endpoints for economic evaluations? That would very much help. But also to see that there is a wider economic benefit. It's not just for the patients that the sequences are run, but for the future, there's an economic benefit. And we have no idea, I think in Europe, how to address this or how to value that. And it's not only the societal benefits, because that differs per country as well. Some take them into consideration, others do not. But in this case, there's also some benefit for innovation. And yeah, nobody actually has a clue how to quantify that. And I'm very, it's very helpful to have, yeah, these stories and if countries are perspective in a different way. And of course, we all, yeah, the political situation in Europe is not optimist. But these are the questions that we have. But we first need to know what is the whole genome sequencing pathway for each patient. And we have 4 different use cases, as I mentioned before. What costs do you take into consideration? What benefits do you take into consideration? And it varies per country. And what I knew, we had a visit to Genomics England, virtual. They were shaping it, the pathway, to make it cost benefit. So all the test itself does not cost that much in comparison to the analysis. It takes a lot of analysis. So our most struggle is to define that pathway and how to consider the clinical benefit for the patient at first, and then these larger benefits. And there are no methodology available at this moment in time.
Well then, okay. Sagira, you've got your hand up. I'm going to actually not come to you first. I'm going to go to Paul first, and then I'm going to come to you, Sagira. Paul.
Thanks, Kate. So, I mean, my response to your question, just from the experience of working with multiple countries over the last few years, is a common framework. That's what's required, but the ability to adapt it by country, to provide country-specific inputs, actually to weigh up different decisions. You know, if you were to make a decision around a certain stakeholder being the focus of your attention, what implication does that have for the other value benefits that might be perceived by some of the other stakeholders, so that you can weigh up and evaluate the choices you may have in a program and see the implications of those. And then again, to Rob's point earlier, yeah, there are some people, in some cases, you may be pitching the story, the response, the output to someone who's a health minister who's not worried about the details but wants to see the big picture. And there are other people who want to take the model apart. You know, they want to see the granular detail and know that it isn't a black box, but they can just, you know, can see the justification behind some of the outputs that are created by it. And I think the key thing for me is to be able to have some consistency as to how you compare that across countries. And so that you've got the opportunity then to help people who are struggling to make the cases to look at other countries' cases, maybe not the sensitive data around the specific inputs they had, but how the decision-making process happened, how they used the kind of framework and the decisions that were incorporated in it to allow the program to move forward. And just the final point from my side, Kate, is that I think you can use them before you've initiated your program, create an output. You can help them to evaluate decisions, but you can also use them to monitor and track progress. And that would be incredibly powerful to be able to share the insight over time. And for me, that's my answer to your challenge, is like, what do we need here? And I think we have it. It exists in a form. It's just a question of how do we get it out to the people?
Well, I think that the idea that it exists in a form is quite exciting. Where is it?
It's currently sat within Illumina.
Right.
But it needs, let's have a discussion with Illumina about whether there's a possibility that it could be used. Now, I do mention the challenge we had in the past. I'm by no means saying it's a finished model, but the principle of it around it needs someone, as it were, one step removed, to take the model, apply it, and then make it available to the community is my suggestion, just from where I'm sat at the moment.
Yeah, I have spoken to Miriam Gargesi about it before. Anyway, maybe we'll follow up with her. Sagira, you had your hand up.
Hi, thanks, Kate. Fantastic discussion, not just for today, for the last few days. And I'm really pleased that we have eventually got to, at this stage, that we are addressing this as a big topic and big area of concern, and how important diversity is for genomic studies. For those who don't know me, my name is Dr. Sagira Malik Sharif. I'm one of the principal genetic counselor at Yorkshire Regional Genetic Department here in UK, and previously have worked very heavily with British Pakistani population as well, and working with some of the senior health policymaker in Pakistan as well, and working really hard to make them realize that how important it is to create, to set up genetics and so that it become a part of their routine clinical practice. So the progress is certainly there, very slow, but we are slowly but surely getting there. I have asked this question, so many of you who were there yesterday, that we know with our experience that rare genetic condition have significant, profound implication for the family, social implication, physical implication, psycho-emotional implication. If Mark have touched on this, that parents struggle with even one of them don't work, because if they are looking after for an affected child, bringing them to clinical appointment and all those kind, and the strain on their own relationship as well. And we forget the impact on the other healthy sibling as well, because the parents are so busy with the other looking after the affected child, that they almost kind of forget that there is a normal child there who need looking after, and that there is a lot, if we do ever go and do the study on the impact of genetic disorder on young children who are living with this condition and with the parents struggling with these. On clinical aspect, I've discussed that yesterday as well, and kindly Dan Suhail is going to take that up, and we are going to see if there are certain genetic tests we can set up, like with our experience with British Pakistani population. We've learned that primary ciliary dyskinesia is clinically a similar disorder than cystic fibrosis to a certain degree, is more prevalent in Pakistani population, and the carrier frequency is same as cystic fibrosis in Northern European as well. So what my suggestion was that can we not develop a simple test, because the diagnosis of primary ciliary dyskinesia is quite long when it step, and you have to do a multiple step before you get that. But if we can put that as a kind of genetic screening test for Pakistani population, that may be helpful. Same with, because it is very completely heterogeneous condition, multiple gene involved, setting up that test. And I'm glad, Kai, you were not there in the afternoon session as well, that there are a lot of people from the industry came to me who are developing these tests, that how can they help as well. At the same time, I raised the question that a TTR-related mutation, which can cause the amyloid cardiomyopathy, that's one of the specific mutation is responsible for undiagnosed heart failure in African American. And the literature shows that the carrier, it's a dominant disorder, carrier frequency is 3 to 4% as well. But if we can provide a genetic test for that, a clinical relevant test for that variant prevalent in that population, that give us accuracy in not just in diagnosis, but for the clinically managing those conditions, provide economical benefit for the organization as well, who are going through number of testing to get to the diagnosis. So these are the areas I think we probably need to focus if we really want to see the economical benefit, that there are some certain tests we can develop. Same with the areas where the prostate cancer is common in African men. And there are some areas in the UK, I know, because there is special interest in that from the professional, and they're setting up the screening program. We can set up the screening program for men, prostate screening for men for African origin across the globe as well. That screening probably will not be as economically cost involved as comparing with so many people who are diagnosed with prostate cancer as well. So the economic burden of treating those would be greater than just offering a screening program. So thank you.
No, thank you, Sagira. Look, to me, all of these themes are interrelated. Okay, so we all start off with, oh, isn't genomics amazing? Yes. Are we bringing the benefits of genomics equitably to everybody? No. Why aren't we doing that? It costs too much. Why are we not doing it? We don't know how to evaluate. Why are we not doing it? Blah, 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 blah. But there are loads of examples that are coming up through this discussion that I think can be used to sort of demonstrate, you know, there are other issues at play, I would suggest, as to why these things are not being actioned. Rob, can we maybe just come to you just in terms of how you're as a funder, and we've talked about the role that funding agencies can have in trying to address some of these challenges that are faced globally, frankly speaking, with respect to all sorts of different things. We've talked about it before in conjunction with you know, improving diversity in the entirety of the genomics ecosystem. But how is your approach as a challenge approach? How does that impact with kind of these economic and other impacts that we're talking about?
Yeah, thanks, Kate. And thanks for the great conversation. And as you say, I think there's a lot, like all of this is interrelated, you know. I think when we're thinking about impact and we're thinking about, you know, the economic impact, but also social, environmental, and so on, you know, community impacts and so on, we're often, you know, I think trapped by this thinking that we're measuring the impact after the fact. You know, we make an investment, then we just sort of see what happens. And frankly, when it comes to the research kind of funding environment or just research in generally, you know, we maintain a and a bit of an outdated concept of kind of like trickle down benefits, right? We know it's not true for economics, but we still sort of believe it's true for research, that if you just make investments in research and you have great discoveries, everybody's going to benefit. And we know that that's just not true. We know that the benefits don't, aren't equitably shared, that they, accrue to those who have a hand in actually shaping the questions that are being asked. And I think we need to be much more deliberate, not just about measuring the impacts of, doing great science, but of actually identifying before the fact the types of impacts we actually want to achieve and how those impacts will be actually shared and distributed. And then we can measure that as well. And so for us at Genome Canada, we have I think a proud history of supporting lots of really great research over the years, but we really did approach research with this bit of a kind of an agnostic perspective. We're going to invest in health genomics, we're going to invest in agricultural genomics or what have you, and we're going to support great science in an applied way, and then those benefits will improve kind of the lot across the board. We've realized now that actually in many ways the whole doesn't actually exceed the sum of its parts, and in fact there are certainly individuals and groups who are underrepresented when it comes to those benefits. We've adopted a different approach now, what we call our challenge-driven approach. And it's not, many of you will be familiar with other kind of mission-driven, kind of approaches to funding research and so on. We've done that, but we've done that in order to be really deliberate at the front end about the types of impacts we actually want to identify, and then designing that kind of research funding opportunity around really specific, much more specific impacts. So for instance, we just a couple of weeks ago now launched a major new initiative in genomics around climate change in agriculture and food systems. And in this case here, what we really identified as impacts is really identifying ways that genomics can be used to help drive towards net zero carbon in our food systems. And in that case there, we're being, I would say, much more deliberate about the specific, there's certainly an economic dimension to that, but we worked with communities, including not just the researchers who will do the work and not just the companies, but the communities that are affected by the agricultural practices, to identify, what are the issues, where are the opportunities here, and we've designed our research funding opportunity around those much more, I would say, specific and directed sorts of impacts. So, that's one example right now, but we see the same thing in the health space, for instance, in Canada, where we have, we don't have a kind of a million genome project, because of the fragmented nature of our ecosystem that I mentioned off the top. We have a variety of cohorts across the country that are connected, but those cohorts have sort of just grown up here and there. And what that means is that there are certainly groups in Canada who are absolutely underrepresented. And so we're now working much more deliberately to fill the gaps in that cohort landscape. And for instance, we have a project called Silent Genomes, which works with Indigenous people in Canada to identify barriers and kind of challenges when it comes to data governance, for instance, making sure that we're doing all of the work that we're doing that will align with the UN Declaration on the Rights of Indigenous Peoples, for instance. So we're being much more, I would say, deliberate up front now about designing the opportunities so that we don't inadvertently reproduce the kind of systemic issues in the outcomes that we've seen over the last generations of research funding.
No, thank you, Robin. I think this concept of involving the right people from the outset, so you're actually driving the correct output, not sort of just doing something that you think might be useful. This whole concept of having the right people in the room at the beginning to work out what the question is that needs answering, rather than just assuming is, I know that you've spent a huge amount of time in Canada on that Silent Genome project, 3 years, because you're so keen to get that governance right with these Indigenous communities. And we've learned a lot in our various discussions about the importance of language and the importance of, we have to stop this whole concept of helicopter research. We've got to enable communities to be able to benefit themselves. And I think that that's why, Manop's examples in Thailand, saying we had to start. We can't just we don't want to outsource all of our sequencing like they have to do in Latin America. Anyway, there's a whole load of things in there. Ilse, you put something into the chat, which I would like you to expand upon, if you would.
Okay, I raised my hand as well, but
both are available.
Saying it's a while ago, but We worked with the Illumina macroeconomic model, and we had some sessions with that, and it worked very well. So I support Paul's point that there is a lot of value in that model. And of course, it's from a commercial company who has a lot of interest in this topic. But I think also the receiver should be able to justify what is right and wrong. And they can adapt the model. So yeah, but it's now in the hands of Illumina, and it's not being worked on, I think. So we'll work on that further. But it was a very nice exercise for the Netherlands, at least. And I think we provided a lot of data to or information to Illumina. So that was my first point. But I wanted to react on the latest presenter about the political agenda. So we have the climate, which is also in most of the European countries at first. And genomics is less important, and UK has no problem with it. And there are a lot of investments in it. But for the rest of the European countries, we have the war in Ukraine. It's very hard to get finance for a genomics project. And it would be of very interest to explore the various economic benefits of such a project. So I was a little bit curious about the other participants, how they think about it, but the times are challenging, I have to say.
Mm-hmm. I think that this is one of the things we talk about this quite a lot. A lot of our work focuses on human genomics. We also touch on, pathogen surveillance and, sequencing in relation to the pandemic and so on and so forth. But there are lots of applications that genomics can have. And we know through the pandemic that a lot more sequencing capacity has been deployed globally. But is it right to assume that all of those jurisdictions that now have sequencing capacity should be turning all that on for rare disease and precision medicine? I just don't think that's realistic. That this concept that Canada so neatly articulates, that there are other great, utilization of genome sequencing that can, you're right, what is the largest challenge that faces us? Getting everyone in the world's genome sequence is probably not right at the top of the list, but climate change. And Rob, maybe you could elaborate a little bit. I'm really fascinated, and I keep trying to persuade Genome Canada to do a World Economic Series session about this, because I think the application of genomics in response to the challenge of climate change is something that we need to kind of promote more, because it might be that some of these jurisdictions where they have sequencing capacity, they could use it for that, in amongst other things, antimicrobial resistance. I know Julia is always telling me in terms of, malaria and TB, not, oh, look, we found 2 people in outer Timbuktu that have got this rare disease. Okay, great. But is that really the focus? But Rob, how do you in Canada use genomics to address some of the challenges of climate change? Because I think that that's actually really quite interesting point. We sometimes just get a little bit caught up on human genomics. That's fascinating. If you could enlighten us, that'd be great.
Yeah, sure. I'll say just a few words. I think from our perspective, really, when it comes to climate change, there are sort of 2 applications for genomics, broadly speaking. One is on mitigation and the other on adaptation. On the mitigation side, it's really looking for ways to reduce the carbon footprint of existing systems. And that could be everything from, agricultural systems, whether that is improving, for instance, the soil microbiome so that you perhaps have different, applications of, say, fertilizer and so on. That could be in the energy sector. Certainly here in Canada, we have a high carbon production energy sector with the oil sands. So are there ways that we can actually either reduce the carbon footprint of the oil sands, or rather identify, say, alternative energy sources using kind of biofuels and so on. And even something as simple. I mean, my kids always laugh about the idea of reducing methane emissions from livestock, but that's a real it's a real area of research certainly here in Canada. On the adaptation side, Of course, Canada being a northern country is going to be very sensitive. I mean, as all countries are, but for us, our food systems, our forestry systems, and so on are going to be significantly affected by changes to the climate, everything from drought to heat, invasion of new pests, and so on. So we are working with food producers, for instance, to work with kind of like wild cultivars that are related to our main food production crops to identify drought resistance genes and so on. We work with our federal and provincial governments on, say for instance, policy and regulation when it comes to new gene editing technologies as well, to help be able to react to the changing climate. And forest, even something like forestry. At this point here, the trees we're planting are already about 200 kilometers out of range and are subject to new pest invasions and so on. And genomics is really helping us to, I would say, accelerate a lot of the adaptation side of things. And the same is true in our aquaculture, fisheries, and so on. Never mind, there's a whole other world of biomonitoring, for instance, and the use of eDNA, particularly in the huge, sort of large sections of the north, which, are sparsely populated, but for whom our northern people are, reliant on, as they say up there, food security. Up here, food has fur. And so figuring out, how we can make sure that we have sustainable populations of wildlife, for instance, up north, tracking that is very, very difficult. But the use of eDNA technology, for instance, is helping biomonitoring. So there's lots of ways that we're actually working on climate change issues, and genomics is at the core of all of it.
And is it easier, coming back to the central point of what this is all about, do you find that it's easier to articulate the economic benefits in relation beyond human healthcare? And I just feel that this human health is just like, I mean, it's essential, obviously, but it's very fraught. Is it easier to get buy-in beyond the field of human healthcare?
No, I mean, and so this is, I think, an important point. I mean, the short answer is no, not really. I mean, honestly, it was only really during COVID that even my parents finally got what genomics was all about, right? When they finally said, right, like when it comes to human health, when it comes to pathogens and so on, that is really still what animates, I would say, the greatest, interest and motivation, and for good reason, I think that will change. I mean, I do think, regardless of, what we are doing at Genome Canada, the advances we're making in just kind of biotechnology writ large are going to be felt across a whole wide swath of different sectors. And so it will become more and more, a part of just the kind of the general conversation about economic growth, about reaction to climate changing and so on when it comes to a lot of our living systems. But certainly it brings different people to the conversation. So it's not just trying to talk about, how much do you invest in, say, critical care capacity versus, genomic screening and so on. We do work with the Departments of Agriculture, the Department of Energy, Department of Natural Resources. So it's a very different sort of set of stakeholders.
No, perfect. I just think it's just so interesting. I mean, Manop in Thailand, Genomics Thailand, I think that your colleague Prasit's on the line, and Genomics Thailand is only in relation to human healthcare, but you do use genomics more broadly. And I think Prasit, we've met before, is talking about that broader application of genomics. But, maybe he would like to say something. Julia Wilson at the Welcome Sangha Institute is put her hand up. Let's hear what Julia has to say.
Thanks. Can I just check you can hear me, because I've got a different headset? Perfect. I just wanted to come back on the sort of non-human projects and the potential value of those, and where they can be funded. There is a global effort called the Earth Biogenome Project to sequence the 2 million eukaryotic species on the planet. Everybody thinks it's a super idea, and some funding agencies are putting in piecemeal. In the UK, we've got the Darwin Tree of Life project, which aims to sequence all of life in the UK. And that is by far the largest commitment so far. And there's an element of, it's a great idea, but nobody wants to fund it, because that funding at the beginning, unless it's, an organization such as Wellcome that has funded this project, because the academic discovery science costs money, and you need that input at the beginning, and you need to generate that knowledge base before anybody can then extract value from it. And we can see the value. It'll be new foodstuffs, it'll be new medicines, it'll be biodiversity, it'll make us better custodians of the planet. You can't put a price on that. It's, you know, it's enormous, but still nobody's willing to pony up at the beginning to invest in that hardcore discovery science, and it's not just discovery science just to build the knowledge base where then others can come on and extract and add value in the future. So I just wanted to say, you know, maybe that it's a shout out for pure academic research, which is hugely expensive, but it de-risks for others. That investment, you know, de-risks for then, if it's the NHS to take up the findings, if it's for agriculture, if it's for climate change, that others can, you know, we have to think of that academic science as building that knowledge base, and there's enormous value in it, but nobody else is going to generate that for us. So we've got to step up and do it before others can extract value and before we can put a price on it.
I think that's a really important, we've talked, so the role of organizations such as Wellcome, I think, is particularly interesting. And we have a very advanced ecosystem in the United Kingdom, not least because Sanger, the Sanger Institute was created, Wellcome invested heavily. We created the Hinxton campus, you know, all of that, you know, everything else that goes alongside it, all the companies that have been created, the jobs, the, you know, that golden triangle, as they call it, you know, between London and Cambridge and Oxford, where, you know, all of this work goes on. Other venues are available, but the need of organizations such as Wellcome to actually almost like kickstart some of that stuff, that option is not available in every jurisdiction in the world, and it's not really going to be up to Wellcome to fund every single project in the world. And that's I think the really interesting challenge. How I think it must only be achieved by, you know, we've talked about public-private partnerships, by industry investing and supporting in an equitable way, so that, you know, and that seems to be, you hear it so often, this concept that people are frightened or mistrustful, the power dynamic they feel is completely imbalanced. And it must be right that we can create some principles around that, so that people don't feel they're having to start from scratch every time someone wants to have a conversation about whether they should partner with a private sector organization. And I think that's a key part of our, you know, phase 2 of our global genomics program about equity of access and return. Some of these points are, you know, everything, and we've said it before, is all intertwined. Well, look, I'm conscious of time. We're having such a riot. It's only 7 minutes left. Manop, I'm conscious that we've not heard from Thailand for a little while. Would you like to share your thoughts on anything that we've been discussing?
Yeah, I think in terms of genomics, obviously there are broader scope than just human health. One that might convince people to go along really easily is the One Health idea. You know, everything that's related to the human health, you know, either directly or indirectly, you know, could easily, I would say, create economic impact on those. We as a country in a tropical area, obviously, sooner or later will face the effect of climate change. So far, we haven't seen, I would say, substantial project that from the government try to attack those by using the genome technology. We see some of the science project that utilizing this genome technology to address in the agriculture area, like, you know, try to study or come up with a new crops or heat resistant crops, something like that, that I've seen some of the science groups try to develop in accordance with the others partner like Ministry of Agriculture or University of Agriculture, we call Kasetsat University. But so far, we haven't seen the big project similar to Genome Canada that utilize genome technology other than the human health.
Thank you, Manop. I mean, I think I'm right in saying that the application of genomics in relation to antimicrobial resistance, as far as I'm concerned, that's the only positive intervention I've ever heard anyone make when we start talking about antimicrobial resistance, because otherwise they're panicking that we're going to, all, well, I mean, yeah. So yes, I mean, antimicrobial resistance, there are many global challenges, aren't there? And I think it's fascinating to unpick the role that genomics can play in any and many and all of them. So thank you for that. I'm conscious of time, there's just a few minutes left. Ilse, can we come to you and then to Manop, and then Rob, if you can finish off just in terms of your final thoughts. I think it's been a terrific session today. And once again, thank you everyone. But Ilse.
Yes, thank you very much. First of all, we are in equality, and that's not the same across Europe. So Genomics England is the best example to have a lot of investment. Further, I think research is very important, that we can do research, so share the data. And further, we would like to address the economic value. We, of course, like to attract industry, but there are further economic developments which are not being quantified at the moment, or there's no methodology to quantify that at the moment. And we have to adjust to the national standards for each of the every country. So that's basically what I wanted to raise, what the difficulties are, but also there might be some solutions. But mostly if we share experiences and share data, that would be
sharing of experiences. I don't think anyone's come on one of these calls and started a conversation with somebody else that they thought, well, that was a waste of time. I think Manop, you've spoken separately to Mark Caulfield, and I think if Claudia's on from Hong Kong, I think that they've spoken to Mark as well. I mean, he's a fount of all knowledge. But Manop, did you want to say a few words as we come to a close?
Yeah, thank you. I think one of the benefits of National Genome Program is not only for direct economic benefit. I think it's to build up the capacity of the healthcare by using genome technology is the way to do it. I think several countries in the Western world has adopted this National Genome Program, various kinds. I think there are lower or middle income countries trying to do it. There are several hurdles. I think if we could have some lesson learned from the country that has been doing this kind of a national program before, like in the UK, in European area, or in Australia, or even in Canada, I think it's very useful to share and hurdles, obstacle, the problem we have to solve, or something like that. At least we can learn from it, and when we establish national genome program in other countries, we can use this as a lesson, and we can build together all those national program throughout the world.
Perfect. Thank you, Manop. I think you're exactly right. 100%, as always. Rob.
Thanks, Kate. Just first, a big thanks to Public Policy Projects for convening the discussion here and for the conference, and to the fellow panelists and everyone who intervened. It was a really great discussion today, and I think this is exactly right. Sharing of experience and information is always valuable because each jurisdiction is different, but we share a lot of common challenges. I think, you know, for me, just always trying to I always keep that kind of impact in mind, and trying to figure out whether it's economic or otherwise. You know, how are we able to contribute? Making that argument is essential, but it also doesn't happen in isolation. You know, we're part of an ecosystem trying to address health problems, you know, health inequities, you know, health challenges. We're part of an ecosystem trying to address climate change and so on. So finding bridges also that connect across to other efforts, you know, whether that's other technologies like AI or what have you, or whether that is, you know, across to our friends working in the social sciences and so on, is really important. An ecosystem approach is important. And maybe I'll just take a last second just to underline Julia's point that, you know, while we, especially at Genome Canada, do a lot of work, most of our work in that applied space, investment in that fundamental research is crucial to be able to do that applied work down the road. And things like the Earth Biogenome project, for instance, the site is the type of, you know, investment that we make today that pays the dividends that, say, the Human Genome Project did, you know, 20 odd years ago, to be able to confront the challenges we're going to face tomorrow. So, you know, it really is a shared ecosystem approach across not just the global genomics community, but with our colleagues beyond. And I'm happy to have made the connections I made here today with all of you.
Hooray, 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 hooray. That's what I say. Look, it's been wonderful. Thank you ever so much to everyone who's participated in our Global Genomics Conference this week, whether on the virtual sessions or in person. As I mentioned at the beginning, all of those sessions have been recorded, and they'll be up on the website probably in a week or so. And it's been an absolute pleasure and privilege, as always, to have these discussions with so many of you. And we will be continuing our Global Genomics program of work, probably if people are not all on holiday in July, but we'll be in touch. And if anyone is interested in hearing more about any of our work or how you can get involved, then of course, just please get in touch. But thank you so much. And I hope to see you again soon. Thank you very much. Take care. Bye-bye.